Good afternoon, everyone. I'm Professor Lionel, a cardiac subspecialist, and today we'll be having instruction course on fighting mycotic keratitis. Till now, we have been listening about the orbital invasion of fungus, which happens in immunocompromised conditions. We are now going to talk on mycotic keratitis, which also happens in immunocompetent people. So
Yes,
it is. Hope my screen is visible for everyone. I'll start with an introduction. Hope my screen is visible.
yes, sir.
Okay. So we are fighting mycotic keratitis. Fungal keratitis, the first documented case was in 1879, and the incidence is growing over the last 45 years. In a country like India, it accounts for more than 40 to 50% of all microbial keratitis. If not treated promptly, can result in infection of the globe and loss of globe. So early diagnosis and aggressive management is essential. It gained momentum in 2005 when there was an outbreak, especially in Florida. You can see the rising cases till May, and after which it gained momentum. The difference between fungal and the bacterial is that fungus generally they respond poor to therapy and they have limited availability of antifungal agents. More than 100 different fungal species have been identified to cause fungal keratitis. The specific type of fungus responsible for keratitis also depends on personal risk factors, regional temperature, climatic conditions, and in addition to trauma with vegetative matter, immunocompromised state like diabetes mellitus, ocular surface disease, contact lens wears, in addition to some of the other factors in country.
I would request rest of the speakers to please.
All right. Sorry about the interruption. So, in addition to certain other factors like use of over-the-counter medications, abuse of steroids, topical steroids, and use of native medications in part like ours. So, clinically, it may be challenging to diagnose a fungal infection, and most often the culture reports are delayed also. So, a high index of suspicion is therefore usually required to treat fungal keratitis. When we compare with the incidence of other developed countries, most of the developed countries has bacterial corneal ulcers as major source of microbial keratitis, whereas India and Nepal has fungal as major source. This is comparing some of the publications. In South India, 340 cases per year of fungus is being shown in a single center against 100 cases in 11 centers in USA. Over a period of 10 years, in a study from Hyderabad, 1,360 patients had fungal keratitis. Similarly, in China, 2,065 over 9 years. As I said, the prevalence of specific type of fungus are related to one is a specific type of trauma like vegetative matter, use of contact lens, where fusarium is more common. Candida is more commonly associated with OSD, and agricultural are mostly involved, and similarly personal hygiene and risk factors are also associated. This is one of the recent publications in 2020 October talking on the epidemiology, and it's been published in the Lancet. You can find since 1946 all the different papers have been studied. 116 studies were taken into consideration with 18 different defined population groups, and over 1 million cases every year is known to have fungal keratitis, and 8 to 11%, nearly 1 lakh eyes are being removed annually following fungal keratitis. And what did this paper add? Fungus is one of the most important cause for unilateral blindness, and 3,600 publications have been studied. And if culture negative cases were assumed to be fungal, it is over 1.4 million cases is the burden of fungal keratitis every year. And Calcifer White is superior to potassium hydroxide mount, KOH mount. Probably 1 lakh eyes are being removed every year following fungal keratitis. And it is in the southern Asia, especially India and Nepal, 73 out of lakh population are suffering fungal keratitis, which is the huge highest among all different nations. As I said, over 25 per million per lakh population is the incidence of fungus in India. Similarly, more than 45% of all microbial keratitis are fungus in India. This graph shows a non-fungal, when there is a diagnosis of non-fungal keratitis, the GDP is not much affected, whereas when there is increasing diagnosis of fungal keratitis, the GDP goes down. That means fungal keratitis not alone cause legal and social blindness, but also cause economic blindness, reducing the economy of the country. In India, in our part, Fusarium is the most common fungus. In North India, probably Aspergillus is more common. Morphologically, fungus is divided into dermaticeous or filamentous fungi. Aspergillus, Fusarium, Curvularia are the commonest filamentous fungi, and non-filamentous fungi, which are yeast and yeast-like organisms, Candida. This is a classical Fusarium. A fungi is identified by the sporangia and the spores. A classical tennis racket-shaped one is Aspergillus. When the pigmentation is dark, then we call it as Niger. And bacteria like fungus, yeast-like fungus, are the Candida albicans with pseudo-hyphae. So fungal keratitis pathogenesis is typically, we know it's caused due to vegetative matter and happens in previously healthy eye. Non-filamentous Candida occurs in pre-existing OST. Fungus gain access through the stroma, and it also can penetrate the intact Descemet's membrane. That's why we say hypopion is infective in fungal keratitis. Some of the landmark trials, the mycotic ulcer treatment trial, MUT1 is one of the landmark trial where we studied natamycin is better than imidazoles like Orichonozole in treating fungus, especially with Fusarium, where there is 4.1 Snellen's lines visual acuity gains. So this is a graph showing natamycin is superior than that of Orichonozole in Fusarium. So the MUT2 analyzed if addition of 400 milligram BD of Orichonozole as a loading dose for day 1 and 200 milligram BD for 20 days, does it reduce the need for TPK, or does it reduce corneal perforation in fungal keratitis? But we didn't find any significant difference between placebo and Orichonozole, oral Orichonozole group. That means oral drugs did not help much. They had no benefit rather than topical treatment. So some of the secondary analysis of MUT after 6 days, that is after a week, if a repeat culture is done, 31% had repeat culture positivity. That means nearly 31% of fungal infections did not respond in the first week to the treatment instituted, and those cases were significantly associated with worse visual outcomes by 3 months, or larger scar size by 3 months, or they required penetrating keratoplasty. So that is what is one of the secondary factors which is known from MUT1. So although our ultimate goal is to improve vision and to minimize scarring, but our immediate objective is to eliminate the infection from the cornea. So that should be our immediate intention. In non-responsive cases, clinician should consider after 6 days, based on MUT1, after 6 days, a repeat culture, and a treating physician should think about augmenting current therapy by adding some other medication topically, or starting oral drugs, or some other innovative measures like collagen cross-linking or stromal injections. With this introduction, I would like to introduce my speakers, Dr. Rani Lakshmi, who is a consultant in the cornea department in Dr. Agarwal's Tirunelveli. She'll be talking on clinical and laboratory observations of fungal keratitis. Dr. Sumati, who is a cornea consultant in Chennai, Dr. Agarwal's Eye Hospital, will be talking on medical management. Dr. Preeti Naveen, cornea surgeon in Dr. Agarwal's Chennai, who will be talking on surgical management. Dr. Caroline, cornea consultant in Tirunelveli, who will be talking on some of the newer treatment options. And finally, Dr. Betsy Clement, cornea and cataract consultant in Tirunelveli, will be talking something about cross-linking in fungal keratitis. I thank you all for your patient listening. Thank you. So, as Dr. Rani Lakshmi wished, her presentation to be shared, pre-recorded presentation to be shared. I'm proceeding with that. I hope
I am Dr. Rani Lakshmi.
I hope her volume is very audible, right? Can someone clarify for me?
Yes, sir, it's audible,
Yeah.
pretty much
Thank
audible.
you. Thank you. Thank you so much.
We'll discuss on clinical features and investigations of fungal keratitis. Coming to the clinical features, the major risk factors causing the fungal keratitis includes trauma, the most common one, contact lens use, ocular surface disease, the topical medications including steroids, anesthetic abuse, and broad-spectrum antibiotics, a corneal surgery, and immunocompromised state. The common symptoms in case of fungal keratitis includes the foreign body sensation, slow onset, increasing pain, blurry vision, photophobia, red eye, tearing, and discharge. The symptoms are usually much milder than the clinical signs. Coming to the signs, the non-specific signs in any case of keratitis includes the ciliary congestion, epithelial defect, and an anterior chamber reaction. And the specific signs in cases of fungal keratitis are a dry-looking ulcer with an elevated edge and feathery margin. The fungal keratitis usually they present with a satellite lesion, which are these stromal infiltrates, and they can also present with the endothelial plaques, which you can see in the pictures. The
Ma'am, I'm sorry to interrupt, but we couldn't see the screen sharing.
Okay. Okay. I'm sorry. Screen share.
Yes, we can proceed now, ma'am. Thank you.
I am Dr. Rani Lakshmi. I will discuss on clinical features and investigations of fungal keratitis. Coming to the clinical features, the major risk factors causing the fungal keratitis includes trauma, the most common one, contact lens use, ocular surface disease, the topical medications including steroids, anesthetic abuse, and broad-spectrum antibiotics, a corneal surgery, and immunocompromised state. The common symptoms in case of fungal keratitis includes the foreign body sensation, slow onset, increasing pain, blurry vision, photophobia, red eye, tearing, and discharge. The symptoms are usually much milder than the clinical signs. Coming to the signs, the non-specific signs in any case of keratitis includes the ciliary congestion, epithelial defect, and an anterior chamber reaction. And the specific signs in cases of fungal keratitis are a dry-looking ulcer with an elevated edge and feathery margin. The fungal keratitis usually they present with a satellite lesion, which are these stromal infiltrates, and they can also present with the endothelial plaques, which you can see in the pictures. The hypoion in the fungal keratitis are usually sterile or non-sterile with thick and immobile. They can also present with an immune ring of Wesley, which is due to the deposition of the immune complexes and inflammatory cells. Some keratitis, they present with the gray or brown pigmentations. That's usually suggestive of demataceous fungi like Curvularia. They can also present with stromal abscess. Coming to the slit lamp examination of a fungal keratitis, first thing is we have to stain with the fluorescent to assess the epithelial defect, and we have to assess the corneal infiltrate, assess for the anterior chamber reaction, and avert the upper eyelid to check for the retained foreign body, and also look for the hypoion and check the intraocular pressure digitally. Every keratitis we have to describe, and the ulcer has to be noted periodically. So in the description of the ulcer, we have to look for the location of the ulcer. It can be a central, paracentral, peripheral, or a total ulcer. The shape of the ulcer, which is in which the fungal keratitis, they will not have a definite shape. The margins of the ulcer, usually irregular, rolled out, or a feathery margin. The size of the ulcer is important for the follow-up visit and monitor the progress. The epithelial defect and the size of the infiltration has to be measured separately in two largest meridians. The infiltration, it can maybe single or multiple. Depth, size, and density of the infiltration has to be noted. The corneal sensation, either with the cotton wisp or esthesiometer, can be noted. A diagram, this is a color coding and a diagrammatic representation in cases of any pathology in cornea. Coming to the investigations, the major part of the investigations in fungal keratitis includes, first will be the smear, KOH suspension, culture, detection of antigen, antibodies and endotoxins, PCR and confocal microscopy. Coming to the smear and culture, the instruments used for the collection of the samples are chimeras spatula can be used, or a 23 or 26 gauge needle, or a Bart Parker blade can be used, or a platinum spatula. Usually the scrapings are done under topical anesthesia, that is 0.5% paracaine. In the lower fornix can be instilled. And the paracaine is least bactericidal as compared to the tetracaine and xylocaine. A sedation may be needed in cases of children and uncooperative patients. A KOH mount is usually used to remove the other fibers, leaving the fungal elements which are resistant, and very useful as it can be done quickly and treatment can be started if the fungal ulcer is present. It can detect the fungus, nocardia, pythium, and acanthamoeba cyst. How to prepare a KOH mount is, place the corneal scraping on the clean slide, add a drop of 10% KOH to the specimen, cover the specimen with the cover slip and avoid air bubble entrapment. Incubate it for 5 to 10 minutes at the room temperature and examine the saline wet mount with 10x and 40x magnification. The picture shows the branching septate fungal elements seen in KOH mount. According to the many studies, the KOH has a sensitivity of 61 to 94% and specificity of around 91 to 97% in detecting the fungal keratitis. The stains used are, one is gram stain, that is used for bacteria, yeast, cyst of acanthamoeba. It can detect around 60 to 70% of the bacteriae. The fungal hyphae will have a faintly stained walls with unstained protoplasm. The Giemsa stain is used to locate the viral and the chlamydial inclusion bodies, polymorphs, and mononuclear cell besides the above microbes. Ziehl-Nielsen techniques is used to detect the mycobacteria and nocardia. The acridine orange is used to detect the bacteria, fungi, and acanthamoeba cyst, and Calcifer White for the fungi and acanthamoeba, where it will appear as a bright white. These stains need a fluorescent microscope. The gomerin methamin silver, it's best for fungi. The cell wall and the septa stain black in this and against a green background. A lactophenol cotton blue also can be used to see the fungal elements. The picture shows the hyphae stained in the gram stain. The acridine orange, it is a fluorochromatic dye that binds to the ribonucleic acid. The microorganism fluoresces the orange, whereas the epithelial cells and PMN leukocytes fluoresce the green color. The acridine orange stains accurately predicts the culture results in 71 to 84% of the cases and has been reported to be more sensitive than the gram stain. The Calcifer White and another fluorochromatic dye that binds to the chitin and cellulose in the cell wall of the fungi and acanthamoeba cyst. And these organisms, they stain bright green under the epifluorescent microscopy. The picture shows the fungal hyphae elements under gomery methylamine silver and also under the lactophenol cotton blue stain. A large South Indian series of the study of around 1,352 patients with culture-proven fungal keratitis found the following sensitivities for detection of the fungal keratitis. That is, for KOH preparation, it is around 91%. Calcifer White is around 91.4%, whereas gram stain 88.2% and Giemsa stain being 85.1%. So the culture mediums usually used are, one is Sapporo's Dextrosahar, the blood agar, which is usually used for the aerobic bacteria and fungi, especially the Fusarium. The brain art infusion medium for filamentous fungi and yeast. It might grow within 24 hours also and usually takes 2 to 3 days for the culture. The fungal medium should be retained for a week to declare the negative results. According to the studies, the positive culture is expected in around 90% of the cases. Within 72 hours, it is 83%, and within 1 week, it is 97% of the cases. Increasing humidity of the medium by placing the inoculated plates in the plastic bags enhance the fungal growth. If the cultures are negative, then with a high clinical suspicion, we can consider for the corneal biopsy. A saprous textures agar, it's a universal medium used to isolate the yeast and the fungi. Adding an antibacterial agent and increasing the humidity will augment the antibacterial effect and enhance the fungal growth. The saprous agar, it's a commercially available and typically contains dextrose, peptone agar, and pH is around 5.6. The growth shown in the saprous dextrose agar. The other newer methods of detection includes confocal microscopy, anterior segment OCT, in this where the mycotic keratitis present as early localized or diffuse necrotic stromal cystic space. The other one is the polymerase chain reaction, last one being the genotyping. The confocal microscopy of the cornea has been emerged as a clinically useful non-invasive technique for the early diagnosis of the fungal keratitis. It produces images from the cornea with a resolution of 1 micrometer, so which is enough for an imaging of the microorganisms larger than 1 micrometer, that is usually the acanthamoeba cyst and the fungal hyphae. Brasno et al. In his study diagnosed all the cases of suspected fungal keratitis caused by different fungal species using confocal microscopy with sensitivity equal to direct microscopy and the culture. So the confocal microscopy is a non-invasive in vivo technique useful for early detection of the fungal elements, monitoring and guidance of the treatment, and also determination of the depth of the infection. So the limitation of the confocal microscopy are that the technique is extremely user dependent and need a skilled operator and an experienced viewer. The dense corneal scarring could preclude the proper tissue penetration and also the visualization of the structures.
Ma'am, apologies for the interruption.
Through the confocal microscopy.
Ma'am, apologies for the interruption, but we need to conclude this. Thank you.
Mr. Consuelo Ferrer and George L. Alio from the major part of the investigation in corneal ulcer with a proper sample collection and meticulous reporting forms the vital part of the workup. Thank you.
Thank you so much, Dr. Rani. I truly appreciate her, and let's take the discussions to the end. Meantime, the coordinator kindly, all the talks were scheduled for 12 minutes, so we'll be having time, don't have to worry, it's 12 minutes, okay? And now I call upon Dr. Sumadi to talk on medical management of fungal keratitis.
One second. Is my screen visible?
Yes.
Okay. Good afternoon, everyone. I'll be talking about medical management of fungal keratitis. Fungal keratitis is difficult to treat and has a long and protracted course, and close follow-up is required till the clinical improvement or stabilization is observed. Corneal transplant may be required in severe and recalcitrant cases. Challenges which we face during medical management of fungal keratitis is due to limited choice of antifungal agents, low delivery and viability of these antifungal drugs due to poor penetration of the antifungal drugs, lack of availability of the diagnostic tools to assess the microbial sensitivity of these antifungal agents is also an issue. Management of deep keratitis and toxicity of antifungal agents is also a big problem. So as we see, like fungus has a thick cell wall made up of chitin and beta glucans and other polysaccharides, and cell membrane it has a ergosterol and other cell contents. As this is very important to know the mechanism of action of the antifungal drugs. So antifungal drugs are classified broadly into antibiotics, antimetabolites, azoles, allylamines, and others. those which are important to us will be the polyenes and the azoles. So polyenes, we have amphotericin B, natamycin, nystatin, and echinocandins, we have capsofungin, micafungin, anidulafungin. Heterocyclic benzofuran is rhizophulvin. In antimetabolites, we have flucytosine. In imidazoles, we have clotrimazole, econazole, miconazole, and oxyconazole, and ketoconazole. In triazoles, we have fluconazole, itraconazole, orichonozole, and posaconazole. This is again another classification system based on the mechanism of action. In polyenes, we have large polyenes, nystatin and amphotericin B. Small polyenes are natamycin. So these polyenes, they bind to the ergosterol of the fungal cell membrane, resulting in the formation of the microphore. This increases the permeability of the cell wall, thereby releasing of contents and cell death. But natamycin is an exception which acts by inhibiting the amino acid and glucose transport across the membrane, resulting in reversible inhibition of the protein transport without altering the cell membrane permeability. Natamycin is also called as pimerazine, and it's most commonly used antifungal agent. It is produced from Streptomyces natalensis. It has a broad spectrum of activity. It's available as 5% topical suspension. It does achieve good concentration in the stroma based on the dose related. But due to poor ocular penetration, the aqueous humor concentration of the natamycin is very less when compared to the stroma. So in adverse effects on prolonged use, it can cause irritation, redness, stinging sensation. And other disadvantage may be a little minor when compared to the other antifungal agents, are the deposition of the suspended particles on the ulcer bed and the ocular surface, as we see in the picture. Amphotericin B is the first antifungal drug to be used, and it is produced by Streptomyces nodosus, and it's a broad spectrum of activity. It is poorly soluble in water, highly photosensitive, and hence to be stored in dark and refrigerated places. It is absorbed poorly by oral, and it has to be given intravenously or topical. It is metabolized in liver and slowly excreted in urine and bile. Half-life is 15 to 16 days. For topical use, it is available as 0.15% eye drop. It has to be prepared from intravenous formulation. So 50 mg of amphotericin B, which is commercially available, to this 33 ml of 5% dextrose is added to get the desired concentration for topical use. Ocular side effects, it can produce punctate epithelial erosions and occasionally a greenish discoloration of the cornea. Systemic side effects will be infusion related acute reaction, like in the same terms of fever, chills, vomiting, headache, hypotension. Slower toxicity will be in terms of renal toxicity, impaired liver function, hypomagnesemia, hypokalemia, and thrombocytopenia. So in echinocandins, we have capsofungin, which is the first prototype of echinocandins. It acts by inhibiting the beta-1,3-D-glucan synthase, thereby weakening the cell wall and release of the cell contents. It's not absorbed orally, and hence it should be given intravenously. It is excreted in urine, and half-life is 10 hours. Topically, it is available as 0.5 and 1% eye drops, and intravenously 70 mg of loading dose to be given, followed by 50 mg IV daily. So antimetabolites, we have flucytosine. It's an anti-cancer drug, and inactive form of it is pyrimidine antimetabolite and water soluble, and it is a synthetic component. It acts by blocking the DNA protein synthesis. In fungal cells, it gets converted into 5-fluorouracil and then to 5-fluorodeoxyurylidilic acid, which inhibits the thymidylate synthesis. It is absorbed well orally and crosses the blood-brain barrier, and it is excreted in urine. The most common and the adverse effect will be dose-dependent bone marrow depression and GI disturbances. In case of azoles, we have imidazole and triazole, as I said, and imidazoles are metabolized rapidly and hence have more effect on human sterols, so more drug interactions. Triazoles are metabolized slowly. So these azoles, they bind to the fungal cytochrome P450 enzyme, that is lanastrol 14 alpha demethylase. They impair the ergosterol synthesis and thereby membrane abnormalities and release of cell content and eventually cell death. Orichonozole is available as oral and topical. It is the second most drug which is used topically apart from natamycin, and it has a structure similar to fluconazole, and it is absorbed well orally, and it is less bound to the protein, plasma protein, and it crosses blood-brain barrier very well. It is metabolized in liver, and it is excreted in urine. It has a broad spectrum of activity, and it has a good intraocular penetration. It attains good concentration in the stroma and aqueous humor when it is given topically. Systemic orichonozole gives good concentration in aqueous humor, vitreous, as well as in the plasma. Adverse effects will be for Orichonozole will be in terms of visual disturbances, color vision changes, photophobia, transient visual hallucinations. In ECG, we can have QT prolongation. It should be used cautiously in case of pregnancy or as well contraindicated because of its teratogenic effect. This is the routes of administration of Orichonozole. Intravenously, it is given as 6 mg per kg. Orally, it is 200 mg twice daily, and it is available as 1% eye drop for topical, and intrastromal intracameral 50 to 100 microgram in 0.1 ml. So Orichonozole has to be prepared, or one other form is only one commercially available eye drop is there, which is prepared by Oro Labs, and it contains sterile lyophilized Orichonozole powder, to which we need to have add a 3 ml of sterile water to get a 1% solution. Other form is like preparing with the commercially available IV formulation, which is 200 mg of Orichonozole injection. To this, we add a 19 ml of distilled water to get a 1% concentration. The preparation, which is prepared by sterile water, is stable for 4 weeks at 4 degrees Celsius. Orichonozole for intrastomal intracameral can be prepared by adding 19 ml of distilled water, 200 mg of IV formulation, and from this 1 ml is taken and 9 ml of distilled water is added. So to get 10 mg per 10 ml, from this 0.0 ml, 5 ml is taken to get 50 microgram, and in 0.1 ml gives 100 microgram in 0.1 ml. Ketoconazole is a lipophilic in nature, and it has a broad spectrum of activity. It has a good oral absorption, but depends on the gastric environment. Low pH is required for the oral absorption of the ketoconazole, and it has a half-life of 7 to 8 hours, and it is usually given as 200 mg twice daily. Since it's metabolized in liver and excreted in bile and feces, LFT should be monitored either weekly or fortnightly. Then fluconazole is a first generation triazole, and it has an improved safety profile, and though it has a narrow spectrum of activity when compared to the other triazoles, because of the safety profile, the fluconazole is the preferred antifungal drug when compared to the others. So it has a good oral absorption, and it has a half-life of 25 to 30 hours, and usually it is given as a 150 mg per day. So it is metabolized in kidney and excreted in urine. Itraconazole is available as topical as well as systemic formulations. It has broad spectrum of activity, and oral absorption depends on gastric acidity. Its half-life is 24 to 42 hours. Posaconazole again is a second generation triazole. It has action similar to Orichonozole, and it is highly protein bound and does not cross the blood-brain barrier. Its half-life is 25 to 35 hours. With this overall view of the antifungal drugs, let us go how we are going to systematically approach to a patient who's having a fungal keratitis. So prognosis and success of treatment depends on rapid diagnosis and rapid initiation of the treatment. So initiation of treatment is based on clinical judgment and as well as smear report. Treatment, once you start, you can modify further based on the clinical reports, culture or culture sensitivity report, which you get little later. So topical therapy remains the gold standard treatment till now. So you start with an antifungal drug and a supporting medication like cycloplegic agents. It's to be added to relieve the ciliary spasm, pain, and it also helps in preventing the synechial formation. If you suspect an IOP is elevated, you can add an anti-glaucoma medication. If you feel in the initial presentation the ulcer is a very severe form, then you can add an antifungal orally. So success of the medical management depends on noting the following features, that is clinical characteristics of the ulcers, that is size of the infiltrate, whether it is less than 2 mm or more than 2 mm. As in the first picture, you see it's a small ulcer. For this, topical single drug medication is sufficient. But if it is more than 2 mm, you have to add a single or two medications with an oral antifungal drug. Location of the infiltrate, whether it is central or peripheral, and depth of the infiltrate. If it is more than 50%, then you have to add an oral antifungal. If it is involving the limbus or closer to the limbus and sclera, then you can add 2 drugs with an oral antifungal. Associated AC reaction, hypopion, prior topical steroid use, vertically oriented high pain, corneal stroma, all these things are very important to be noted for the successful outcome of the treatment. Yeah.
I'm sorry for the interruption, but can we please sum it up in next 30 seconds?
Yeah, I will do. I have a few slides I'll finish it up. The final visual outcome in 3 months will be based on the initial visual presentation if it is bad and infiltrate size is large or old age, and large ulcers have a propensity to have a perforation. These we have a Tst Protocol, so which is extensively studied and published by Namrata Sharma et al. It gives a overall idea for all the general practitioners to how to go about the treatment of the fungal keratitis. So initially, when you diagnose it's a fungal keratitis, you can start with a topical 5% natamycin, except in cases where the ulcer size is more than 5 mm and the depth of the ulcer is more than 50%, then you can add a systemic antifungal. You observe the patient for a week. Then if there is a good response, continue the patient observation till the scarring happens. If you feel there is a poor response and severe corneal thinning, impending perforation is there, you take the patient directly for the therapeutic keratoplasty. If not, then you add another topical Orichonozole 1%. If you feel there is an improvement in 7 days, then continue the same treatment. But if there is a worsening, if you see, then you can add intrastomal or intracameral injections. And if improvement is there, again, that will be a same treatment. And if little stay, no improvement, or it's ulcer size is the same, then you can repeat the injections at an interval of 72 hours for 3 to 4 times. If there is no improvement further, you take the patient for therapeutic keratoplasty. These are the few pictures where only small size ulcer, where only topical medications, topical and systemic, and response to the treatment you assess by talking to the patient. Once the patient says that there is improvement in the pain and improvement in the vision is a key factor, and there are signs like supplanting of feathery edges, reepithelialization, reduction in the anterior chamber reaction, scarring, or improvement in vision. And treatment while failure can be because of the wrong diagnosis. Initially, like fungal keratitis can be misdiagnosed in cases of pythium keratitis, which also has a similar characteristic features as fungal keratitis, or resistance to the antifungal drugs, or non-compliance from the patient's side. So then targeted drug delivery will be like, aim is to deliver high concentration of drug to the site of action, considered in severe anterior chamber reaction with deep stomal keratitis or recalcitrant mycotic keratitis. It will be in form of intrastomal or intracameral injection. Another 2 minutes, I will conclude. Intracameral injection for amphotericin B, we have 5 to 10 micrograms in dose. Orichonozole, we have 50 micrograms. So, and then for intrastomal, we have Orichonozole at the dose of 50 microgram in 0.1 ml and 5 to 7.5 microgram in 0.1 ml in for amphotericin B. The reconstituted Orichonozole is loaded in 1 ml of tuberculin syringe with 30 gauge needle, which is inserted obliquely to the corneal stroma through the uninvolved clear area. It can be given in 5 divided doses around the ulcer. Thank you. Sorry, little prolonged my presentation.
All right. Thank you, Dr. Sumati. Nice presentation. You can stop sharing your screen. As I said, we'll take up discussions later. I'll call upon Dr. Preeti Navin to talk on surgical management of fungal keratitis.
Good afternoon, everybody. Today, I'll be talking about the surgical management of fungal corneal ulcer. So the main indication when we plan a surgical management is whenever we feel that the medical therapy is not responding and the patient is having a persisting corneal ulcer. So we're going to discuss surgical management under the below headings. We have debridement, then the application of cyanoacrylate glue, a patch graft, a lamellar graft, and also a full thickness penetrating keratin. So let's go one by one. So when we go to debridement, so why do we do a debridement? The main role of a debridement is we need a better penetration of the drug, especially when patients are on antifungals like natazole, which tends to form debris, and when your penetration of the drug is inhibited, that's when you do a debridement. So indications are basically no improvement after starting topicals on a day 2 or 3. The other advantages is it helps to debulk the organism as well as the necrotic material and enhances better penetration of your topical antifungals. And you could also do a daily debridement every 24 to 48 hours. The next OPD and how debridement is done is it's an OPD procedure. So just after instilling paracaine drops with chimeras or a number 15 blade, the base and the leading edge of the ulcer, scrape gently in a singular direction. The other OPD procedure is the application of a cyanoacrylate glue. So the main indication for a glue application is whenever you have any perforation, an impending perforation, an ulcer which is going in for a melt, and due to lack of tissue, the supply of tissue immediately, you want to salvage the globe. Till then, you can put in a cyanoacrylate glue. So in cases of melting, thinning, desmatoseal, the glue also helps to inhibit reepithelialization and inhibits polymorphonuclear leukocytes, which are the main source for collagenollytic and proteolytic enzymes, which causes further thinning and a perforation. So it's only a temporary measure till we get a eye for a tectonic or a therapeutic patch graft. So glue application is again an OPD procedure under Paracane. We make sure its speculum is placed, the entire ulcer is exposed well. And if the surface is a little epithelialized, we will have to gently scrape it so that the glue sticks well. And make sure the surface is very dry before you apply the cyanoacrylate glue. And put in the glue gently and making sure that there is not much of spillage onto the normal cornea or conjunctiva, because it gets too messy. Try to put a thin layer, and once you feel the crystallization has happened, then you put on a contact lens. Then coming to patch graft. So patch grafts are indicated basically whenever you have a localized infiltrate or an ulcer which is not responding to therapy. And most commonly we've seen in cases, post cataract surgery, post phaco, and near the site of the wound, if they develop an infiltrate and not responding to treatment, we plan a patch graft. Patch graft can again be a lamellar or a full thickness based on the depth of involvement. Pre-op ASOCT can be done in these cases just to make sure that on table you are prepared for the depth of the lesion. Coming to therapeutic DALC. Therapeutic DALC usually is a little controversial. They say that if we are not able to debride or excise the entire ulcer mass, then there could be chances of recurrence. And second is for the drug to penetrate into the interlamellar space also, it will be a hindrance if we're not able to clear the entire lesion there. So basically, it's indicated in cases of superficial ulcers not involving the deep stroma. Anything which is deeper than 150 microns, not exceeding 300 microns in depth. So again, an ASOCT will help in these cases to pick out the depth of the lesion. And provided the anterior chamber is pretty quiet and there is a poor response to medical treatment. These are some of the studies which have indicated like how beneficial a DALC is when done early in cases of a fungal keratitis, and either done by a manual dissection or by a big bubble technique. So going on to the procedure, it's just like any routine case, a peribulbar anesthesia, and we should make sure that the ulcer edges are marked properly, because you need at least a 1 to 1.5 mm clear area before you take in the graft. And so the recipient cornea is refined deeper, and then a layer by layer manual dissection is done, making sure that at the end of the procedure you are able to take out all the infective material, not leaving behind anything in the interface. The bed is again washed with antifungals and antibiotics, and the corneal button, which is usually 1 to 1.5 mm larger than the original ulcer, is sutured over the recipient cornea. Now coming to the age-old, the gold standard in non-responding ulcers is a therapeutic penetrating keratoplasty. So when do you go in for a therapeutic keratoplasty? Ideally in cases where you are giving a maximum medical therapy, all types of antifungals, oral, not responding at least for 2 to 3 weeks after the start of your medical therapy, then I think it's always better to go on for a therapeutic, because you don't want the ulcer extending till the limbus or going in for a scleral extension, because then the prognosis is very poor. And any corneal abscess with a melt. And the main aim of the therapeutic keratoplasty is you basically debulk the load of infection. So we will explain to the patient that the procedure is being done mainly only for a debulking, and he will need an optical procedure at a later date if there is no recurrence. So the chances of recurrence after surgery also has to be explained to the patient. And the main indication is, again, you want to maintain the globe integrity so that for future visual rehabilitation is an option for the patient. So some things which we have to keep in mind, pre-operative evaluation would be for all patients, you get a PLPR status, check the digital IOP. The size of the ulcer has to be documented along with the rate of vascularization. Lens status, pseudophakic, phakic, and a B scan to check any posterior involvement, because if there is a posterior involvement, then you might need a retina person inside to do a pars plana vitrectomy with intraocular antibiotics. And like all cases, we would give an IV mannitol 30 minutes prior to surgery. You want to reduce intraocular pressure while you're operating, prevent any expulsive happening on table. So those things you give a mannitol. So the routine procedure would be peribulbar anesthesia, no pinky, because sometimes, or a gentle pinky and a massage, because sometimes you feel that the eye is the ulcer, the cornea is too thin, and too much of pressure, it can cause a perforation there also. And so a peritomy is basically indicated in cases where there are large ulcers, a limbus to limbus, where you're not able to assess the extent of the ulcer beyond the limbus. And so if you have to include a little of the sclera, and if it's involving the sclera, then we'll have to take a little larger graft. And the ulcer size usually measured with a caliper and making sure 1 mm of healthy cornea is available. And the donor trephine is usually 1 to 1.5 more than the normal. So I'll be showing you some videos. And so the other thing which you'll have to make sure while you're doing a therapeutic is just make sure you prepare 2 trolleys. So one is while you're excising the host cornea, and you want to make sure all your instruments and your gloves and everything are changed, because you don't want any cross infection or anything going on to the new host cornea which you're trying to. So I will just explain based on this video. So in this video, what you're seeing is it is a limbus to limbus infiltrate, a large ulcer. So we are putting in a Pleringa, measuring the ulcer, and a manual dissection of the graft is done because it's a pretty large graft, probably more than 12 mm in size. And we do a manual dissection of the graft here. And so when you're trying to enter the anterior chamber, always use the side port, go in parallel as much as you can, because you don't know the lens status, whether it is phakic or what. You don't want to damage any of the structures inside. And inject visco and use your corneal scissors, your right and left corneal scissors, and just try to excise all the infected tissue. You might have a lot of tissue sticking on to the lens capsule, and which would be adherent. So just make sure you put in a little viscoelastic under that and try to peel it off as gently as possible. We try not to disturb the lens unless there is an auto expulsion of the lens. We try not to remove the normal crystalline lens. The reason being, we don't want to create a single channel where there could be a vitreous involvement at a later date. So we try to retain the lens, and then antibiotic wash with Vozole or an antifungal wash is given. And here the edges are trimmed, assuming that we were not able to clear it out with the first set. And so making sure everything is done, we put in the graft. While you're placing the graft, always make sure that if you have a scleral part to it, make sure that it is placed superiorly, mostly for cosmetic reasons. And in a therapeutic penetrating keratoplasty, you'll have to make sure that since the graft, if the graft is a larger size, you will need more sutures compared to your normal 16 sutures like you do in a PK. And also your sutures have to be a little more tighter, because the inflammation is much higher in these cases, and the chances of your suture giving way or gaping is much more in these cases. And so this is another case where I'm just trying to show you about how this is, we're using a trephine over here because it's a more localized lesion ulcer. And the donor graft is again trephine, 1 mm or 1.5 mm larger than this. And as you put in visco, and just like I told you, enter with your side port knife parallel to it so that you don't damage the lens matter. And here also you can see a lot of infiltrates, exudates stuck on the lens capsule, which we will just be peeling off gently. Always make sure you get a proper cleavage plane before you start making your cut, because you don't want to inadvertently damage your lens or your iris tissue or anything underneath and cause excessive damage to the patient's eye. So this is just showing you how adherent the tissue is to the lens and the underlying tissue. And then the rest of the procedure is the same. You just remove everything, excise it, and then give your wash, and then place the graft and your sutures. So these are some pictures to show different presentations of fungal ulcers. The first one is showing a limbus to limbus involvement, a total corneal abscess. Then the second picture on top shows you full thickness infiltrate and with the hypopion. And so these are different presentations. And these are pictures of some of our post-operative patients. Most of them have been large grafts. And in most of these cases, we've tried to retain the lens. Lens hasn't come off. And you can see a corneoscleral graft in certain cases. And obviously the number of sutures and the strength, suture tensile strength is also a little more tighter in these cases. So now coming to post-operative management, medications are given and lubricants. So whether it is progressing, if it is increasing, then they have to be taken up for a wash or intracameral antibiotics. And in the meantime, we always send in the corneal button for culture sensitivity. So we will have to release the culture report. And based on that, if we want to change our medical management post-op, we'll have to suture removal and follow-up again, because it's a therapeutic case. The sutures tend to get loose very soon because the inflammation and the healing is a little faster. If there is a need for a suture removal and there is a gap, you might have to put in a suture. If not, just remove the loose sutures as and when necessary. And plan for an optical graft after a period of at least 3 to 4 months, because your chances of recurrence and reinfections should be avoided. Thank you.
Thank you, Dr. Preeti. Thank you, Dr. Preeti, for your precise talk on surgical management of fungal corneal ulcer. Now I request and invite Dr. Carolyn to talk on some of the recent advances in non-responsive cases and management of fungal keratitis.
My topic for presentation today is on the recent advances in the treatment of fungal keratitis. Fungal keratitis is the most elusive type of corneal infection related to bacterial and viral keratitis and is associated worldwide with significant ocular morbidity, including ocular opacity, and may cause blindness. If treated well and quickly, it can severely reduce the ocular morbidity. In the past few decades, several new antifungal agents have been developed with improved efficacy, and considerable research is being conducted in the field of management of fungal keratitis, and several newer antifungal agents and drug delivery techniques are being evolved to overcome these limitations and improve outcome. Polyenes are the two major classes of antifungal drugs used to treat ocular fungal infection, including fungal keratitis. Amphotericin B has poor ocular penetration after intravenous administration and is toxic to human cells at a higher dose. In a study conducted by Brunard et al., compared the commercial 0.15% amphotericin B with the liposomal formulation and found that the liposomal form was more stable and less toxic, and also increased the potential amount of loaded drug by 3-fold compared with the conventional form. Orichonozole was either used systemically alone or in combination with topical posaconazole suspension in these studies, and it resulted in rapid resolution of infection in some cases without significant toxicity. It can be thus assumed that posaconazole can be used in cases of mycotic keratitis that are resistant to standard antifungal therapy, and the use of topical posaconazole alone without use of oral preparation needs to be investigated further. Evidence on its use in ocular infections is still limited, but initial results are encouraging. Sponsor et al. Also described a case of keratitis by Fusarium solani resistant to amphotericin B and natamycin, but successfully treated with topical drop associated with oral posaconazole. Comparative control studies with first-line antifungal drugs are still lacking. Alton et al. Reported successful treatment with posaconazole in 2 cases with recalcitrant fungal keratitis that were resistant to conventional antifungal drugs. Echinocandins are a group of newer antifungals which comprise of Capsule Fungi, Mica Fungi, and Anidula Fungi. Matsumoto et al. Have reported successful use of topical 0.2% Mica Fungi in cases of refractive fungal keratitis, and in another study, using topical microfungin 1 mg per ml reported found an efficacy comparable or superior to fluconazole in the treatment of keratitis by Candida albicans and Candida parapsilosis. Topical Calcifer has been used in the cases of fungal keratitis refractory to Orichonozole, but still limited data on the use of echinocandins to treat fungal keratitis in humans. There is need for clinical studies with adequate sample sizes to validate the safety and efficacy of these group of antifungals. Advances in the surgical management include intrastromal injections, collagen cross-linking, rose bengal aided photodynamic therapy. Intrastromal method of drug delivery overcomes a major limitation of topical antifungal therapy, which is poor bioavailability of drugs in case of deep-seated fungal corneal ulcer, providing a depot of drug close to the ulcerated area at a dose of 50 microgram per 0.1 ml in 5 divided doses, from where the drug is slowly released into the infected tissue. Various studies in the literature have found that targeted therapy with Orichonozole as an effective approach for deep-seated recalcitrant fungal corneal infections not responding to conventional treatment modalities. It has also been effective in managing secondary lamellar interface infection for late onset infectious keratitis after DSEC, acrimonium fungal keratitis, and post-PRK keratectomy fungal keratitis. A study done by Sharma et al. Found no benefit of intrastromal injections over topical Orichonozole in recalcitrant fungal keratitis cases not responding to topical natamycin therapy for 2 weeks in cases of moderate fungal keratitis. Similarly, Nikki et al. Found intrastromal Orichonozole to be successful in treating keratitis due to yeast only, but not keratitis due to filamentous fungi, which is in complete contrast to the experimental study results. Intracameral amphotericin B is another targeted drug delivery system indicated with medical therapy with topical and systemic antifungal has failed, especially in cases with deep mycosis, endothelial plaque, and presence of hypopion and or inflammation of the anterior chamber. Concentrated drug injected, as described in literature, ranges between 5 and 10 microgram per 0.1 ml. Amniotic membrane transplantation has emerged as an option to delay or prevent penetrating keratoplasty secondary to fungal keratitis. It can facilitate ocular surface reconstructions in other ocular surface conditions and supports the re-epithelialization of tissue and active components present in the membrane, like nerve growth factors, are thought to reduce pain. In a study, 23 culture-proven acute fungal keratitis patients with non-healing corneal ulcers or impending corneal perforation underwent AMT, out of which 25% of the patients with persistent positive culture for fungus required penetrating keratoplasty, and the visual outcome improved in 17, did not change in 4 patients, and worsened in 2 patients. In a study done by Prajna et al., the extended release kinetics of Orichonozole from the impregnated human amniotic membrane was evaluated, and the ham buttons were incubated with freshly prepared 1% topical ophthalmic formulation of Orichonozole for 5 different exposure time to investigate the ideal exposure time. The drug release kinetics was studied in simulated tear fluid for 5 weeks, and the amount of Orichonozole released at different intervals was estimated using high performance liquid chromatography with photodiode array detector. They concluded that the sustained release of Orichonozole was achieved up to 5 weeks when Orichonozole was incubated with amniotic membrane for all the studied drug soaking times. Orichonozole, thus impregnated amniotic membrane, can be considered for the sustained delivery in fungal keratitis. Lamella keratoplasty has also emerged as an alternative surgical procedure for fungal keratitis, in which only the disease layer of the corneal surface are excised and replaced by donor cornea. In a study done by from China, reported the leading indication for lamella keratoplasty in 2008 was infectious keratitis, and fungal keratitis constituted 67% of the infectious keratitis cases. And another study, 55 antifungal refractory patients underwent lamella keratoplasty with intensive topical and oral antifungal medication, and out of which 93% of the patients, the fungal infection was eradicated, and the remaining 4 patients were treated by a secondary penetrating keratoplasty. Rose Bengal photodynamic therapy. Photodynamic therapy involves the activation of photosensitizers using light of varying wavelengths. In an experimental study, Arboleda et al. Have demonstrated Rose Bengal PDT to be successful in infectious keratitis, but still there are no clinical studies to date to justify PDT with Rose Bengal for the treatment of fungal keratitis. Ameskua G et al. in an in vitro and in a case study evaluated the efficacy of rose Bengal photodynamic antimicrobial therapy and found that riboflavin CXL demonstrated no inhibition of fungal isolate growth, whereas rose Bengal PDAT inhibited fungal isolate growth within the irradiation zone. In addition, a case with this resistant Fusarium keratitis was treated successfully. New targets in immunology involved the role of vitamin D receptor in innate immunity being discovered may be a new target of treatment that can be explored for fungal keratitis. Liposomes encapsulated menin extracts from Candida albicans stimulate the production of antibodies protective against candidiasis in mice. These experimental studies may further facilitate researchers to develop fungal keratitis vaccine and use of probiotics in ocular surface for diseases prevention. Recently, many efforts have been made to improve topical ocular drug delivery by designing various novel drug delivery systems, including liposomes, nanoparticles, nanoemulsions, nanosuspensions, micelles, nanofibers, etc. Several studies have reported encouraging results with novel drug delivery systems. In a study, the liposomal formulation of antifungal drug Orichonozole found to exhibit a sustained drug release profile and an eightfold increase in the amount of drug retained in the cornea after 1 hour of exposure compared with the conventional suspension formulation. The nanoparticle formation of amphotericin B showed a sustained and controlled drug release for up to 11 hours, while the conventional drug formulation released the entire drug in only 4 hours. Nanoparticle formation was also shown better pharmacokinetic properties, including 1.5-fold increase in half-life compared to the conventional solution formulation. It also showed that the microemulsion formulations of fluconazole showed a controlled release profile, releasing 50 to 80% of the drug in 12 hours compared to the conventional drug solution, which released almost the entire drug in the first 6 hours. In a experimental study done by Jane et al., the study used cultural corneal epithelial cells reported enhancing penetrability of formation of the prepared formula particles release the drug for 12 days. Antimicrobial peptides have significant potential for use as antimicrobial agents for ocular and other infections. These are also known as host defense peptides. They are present on the surfaces of the eyes and in tears. More than 500 antimicrobial peptides have been reported. These natural antimicrobial agents act by several different mechanisms of action, such as forming pores in bacterial membranes, resulting in cell death, preventing attachment, blocking entry, chelating ion, and digestion of bacterial and possibly fungal cell walls by lysozyme. View et al. Evaluated the application of synthetic beta sheet forming peptide and IRIK2NH2 for in vivo fungal keratitis treatment in comparison amphotericin B and found that topical solutions of the designed peptides were safe and effective as the clinical used amphotericin B. The authors also concluded that the synthetic beta sheet forming peptides are promising candidates for the treatment of fungal keratitis. Iontophoresis is a method used to enhance penetration of drugs into the skin by application using the low intensity electric current. Recently, Calc and Z and co-workers investigated Orichonozole penetration and antifungal potential in the fungal keratitis model assisted by iontophoresis. The results showed that the iontophoresis assisted group demonstrated the better antifungal activity against the experimental strains Fusarium solani keratitis for log reduction and Candida albicans keratitis compared with the native drug followed by topical ocular application. Further, Orichonozole levels were also found to be the highest in corneal tissue in animal groups received iontophoretic treatment. Thank you.
Thanks, Caroline. On the brief note of alternative therapies for fungal keratitis, and thanks for including the preclinical studies of nanoparticles, peptides, and so on. Thank you, and we'll have a short discussion on it later. The final speaker of the day, the role of cross-linking, if at all any, in management of fungal keratitis. I would call upon Dr. Betsy Clement to do that.
Sir, before we proceed, I just wanted to inform, can we please look at the timings as well while we are speaking? To all the speakers, please have a note of the timings so we can conclude at the right time. Thank you.
Yeah, I just repeat, it's 2:04 now. This talk could go for 10 or 12 minutes, and our session ends by 2:25, right?
Yes, sir.
Okay, we have time. Don't worry. No worries. We have
Sure.
time for
Thank you.
discussions also. Thank you.
Good afternoon, everybody. The topic given to me for today is cross-linking in fungal keratitis. So far, we have heard about fungal keratitis, its epidemiology, its clinical features, and its management. Infectious keratitis, as we all know, is a very challenging situation and needs to be treated promptly and effectively. We have discussed in detail about the importance of the diabetic status and nasolacrimal duct patency, the early suspicion based on the clinical features, the mode of injury, and we have discussed the conservative management and the surgical interventions, which are the standard modalities of treatment. Coming to this newer and a novel modality of treatment, which is the PAC-CSL, photoactivated chromophore for infectious keratitis cross-linking. The corneal collagen cross-linking has demonstrated excellent antimicrobial activity against a variety of common pathogens in vitro. The UV irradiation has a known antimicrobial effect. Riboflavin, when it is photoactivated, generates reactive oxygen species which are microbicidal. The combination produces a cytotoxic effect which is greater than the additive action. Collagen cross-linking, which is a minimally invasive novel technique which was developed in 1999 in Europe in the University of Dresden in Germany, was first documented by Spohr et al. In 1998. It was used to treat keratoconus and post-refractive ectasias. Cross-linking induces collagen crosslinks in the stromal collagen of the cornea. It stabilizes the cornea biomechanically by inducing a photochemical reaction which facilitates the strengthening of the collagen lamellae in corneal stroma. The main components being a photosensitizer, effective and a safe light source, and the presence of oxygen. The basis of cross-linking depends on the activation of the riboflavin to a triplet state, a release of singlet oxygen and superoxide anions, ionization of the amino groups, resulting in the formation of new bonds within the stroma of the cornea, giving a stronger cornea. These mechanisms were discussed in detail by Scott McCall et al. In his publication. The two types of cross-linking photochemical reactions that are documented are the type 1 reaction and the type 2 reaction. The type 1 reaction involves a continuous UV radiation and a low oxygen presence, which leads to hydrogen peroxide release, which causes the cell death and scarring, and a limited cross-linking. Type 2 reactions utilize pulsed UV rays and then the presence of adequate oxygen and a singlet oxygen release produce safe and effective controlled cross-linking. The Dresden Protocol, that is the standard treatment modality, involves epi of the central 9 mm zone of the cornea is exposed, and application of the isotonic riboflavin for 30 minutes at 5-minute intervals with the UVA light exposure at the 365 to 370 nanometers wavelength for 30 minutes. The power delivered is 3 milliwatts per centimeter square, delivering a total fluence of 5.4 joules per centimeter square. The minimal corneal thickness of 400 microns is required to prevent any endothelial damage from cross-linking. The anterior segment optical coherence tomography being a useful tool before the procedure and after the procedure. The Tst Protocol has its own pros and cons. The abrasion of the cornea produces results in pain, watering, and difficulty to the patient. The complications also can result due to the infection setting in or because of this epi-off procedure. The modifications that are made to this protocol deliver the total fluence of 5.4 joules per centimeter square, but at a different timing. The Bunsen-Roscoe law of reciprocity, it states that the effect of a photochemical or a photobiological reaction is directly proportional to the total irradiation dose, irrespective of the time span over which it is given. This was proved to be valid for illumination intensity up to 45 milliwatts per centimeter square. Beyond this, the efficacy was came down, and the irradiance time that is needed is more than 2 minutes. The protocols documented are the accelerated cross-linking delivered at 10 milliwatt per centimeter square for 9 minutes, and flash cross-linking delivered at 30 milliwatt per centimeter square for 3 minutes. Cross-linking, the collagen molecules are bonded firmer and resulting in a stronger cornea. PAC-CSL studies have shown novel methods such as cross-linking to be effective in antimicrobial action and in strengthening the cornea. It was first demonstrated in non-infectious and infectious corneal melts resistant to therapy. It was extended to infectious keratitis as first line of management in 2011. PAC-CSL was created at the 9th Cross-Linking Congress in Dublin, Ireland in 2013. PAC-CSL has been applied for severe keratitis, and good results have been documented. Corneal collagen cross-linking is a potentially useful treatment in selective cases of infectious keratitis. Routine use is not supported in fungal and amoebic keratitis. Treatment effectiveness is limited by depth of the cross-linking, therefore more useful in early keratitis. Better response have been documented with superficial corneal infiltrate involving the anterior third of the stroma. Cross-linking may play a role in drug-resistant cases. Small central ulcers associated with higher success rates in bacterial and fungal keratitis. The presence of hypopyon is associated with lower success rates. Various studies conducted where cross-linking was used as adjuvant therapy and where cross-linking was used as a monotherapy. In fungal keratitis, Tabibian et al. And Fisher et al. Have published their findings, giving good results. PAC-CSL gave overall 87% success rate, which was defined as a complete reepithelialization and infiltrate resolution. Results similar to topical antimicrobial therapy were documented. There is a significant shortening of the time taken for reepithelialization in early cases of keratitis. In advanced cases, no difference in reepithelialization and final visual acuity was documented, but the treated groups had less recurrences or perforations. In borderline thin corneas, you have to take extra caution based on the intraoperative pachymetry. Maybe the use of the hypotonic riboflavin would ensure endothelial protection. In patients with the history or suspicion of herpes simplex, riboflavin or UVA should not be used. Herpes infection is reactivated by ultraviolet radiation. Fluorescent staining should be avoided before use of photoactivated riboflavin, as it competes for absorption of UVA light and reduces antimicrobial efficacy. So you must remember that the Dresden Protocol was not designed for infections. So a balance is struck between the size of the epithelial defect that is created. Very large epithelial defects to be avoided, which would delay healing. In small ulcers, fungal keratitis, removal of epithelium beyond the area of observed infiltrate may be needed to improve the riboflavin penetration. Riboflavin concentration may be altered to improve the killing effect. Higher concentration, 0.25%, has a better fungicidal effect. Lower concentrations, like 0.03%, with longer UV exposure have been documented to give better bactericidal effect. Prolonging the installation time increases the collagen compaction and increases resistance to enzymatic digestion. Accelerated protocols have been used for fungal keratitis safely. In thin corneas, other variations like the hypoosmolar cross-linking, transepithelial cross-linking, and iontophoresis assisted cross-linking have been used. Currently under clinical trials are the modified riboflavin molecules, which are enhanced to penetrate intact corneas, the ribocross TE, the ribostat CXLO. In the epi-on state, they are being shown to have better penetration, good effects. Contact lens assisted cross-linking, as documented by Jacob et al., can also be used. Cross-linking, since its inception, it has come a long way for the past 20 to 21 years. Cross-linking, the advances would be pulse cross-linking has been advocated, customized cross-linking has been advocated. In refractive surgery, the pixel cross-linking has been applied. LASIK extra has been applied in refractive surgery. A customized delivery of cross-linking is developed in adapted fluence technique. Clearer cross-linking has been advocated for myopia. CLARE is a cross-linking assisted infection reduction trial. It is interventional trial, phase 4 stage, conducted in Aravind Eye Hospital, Madurai, supported by the University of California. It concluded there appears to be no benefit of adjuvant cross-linking in the primary treatment of moderate filamentous fungal ulcers and may result in decreased visual acuity. The Swiss PAC cross-linking, it was conducted to assess the safety and efficacy of PAC-CSL as a first-line treatment for infectious infiltrates and early corneal ulcers. Mixed ulcers were taken and compared to the current standard care of antimicrobial therapy. It was an interventional trial conducted from March 2016 to October 2020 in the University Hospital Geneva, the principal investigator being Farhad Hafezi. Cross-linking in therapeutic penetrating keratoplasty graft, the study conducted at the All India Institute of Medical Sciences, conducted by Titiyal et al. Has considered the primary outcome of incidence of graft infection, secondary outcome of graft clarity, visual acuity, and deep vascularization. They concluded that cross-linking treated donor corneas may help to reduce the incidence of graft infection after TPK in fungal keratitis, and a beneficial effect is observed in terms of visual acuity and graft clarity. The article is in press, the AO journal. Concluding, cross-linking is an useful non-invasive treatment modality for fungal keratitis. It needs to be used early in superficial ulcers, not as effective as in bacterial and acanthamoeba ulcers, not very effective in advanced ulcers with hyperpion. Donor corneas can be treated with cross-linking for therapeutic keratoplasty. Further studies are needed to arrive at protocols for this modality, but definitely timely intervention and follow-up will help treat fungal keratitis using cross-linking. Thank you.
Thank you, Dr. Betsy. And we come to the conclusion of all the talks. Let's open up for discussions. I have certain quick points to be made. One is Dr. Rani with us in the panel. So what do you think is the pathognomonic sign of fungal infection? One. Number two, in a center which doesn't have confocal microscopy, for the benefit of postgraduates and fellows, which do you think is very sensitive, very specific for your clinical diagnosis help? Are you around?
Yes, sir. Yes.
Yes.
The sign which is pathognomic is the high dry-looking ulcer with the hyphae margin and with the satellite lesions. They get the fungus get the access through the defect and starts multiplying in the stroma, which divides circumferentially, causing the satellite lesion.
Okay.
The hyphae
so a feathery lesion, satellite lesions, immune drain, dry-looking state. You make a clinical diagnosis, and when you don't have confocal microscopy, what do you believe on?
You can go for KOH mount and cultures. KOH mount, it has a very high specificity.
Fungal cultures and KOH mount. Okay, thank you. So, Dr. Sumati, as we know, we understand in our region, filamentary keratitis is the most common thing, and natamycin is, of course, the first line of choice. So, what are the early signs of resolution of fungal ulcer? One. Number two, when do you claim the treatment is on a failure side? When do you add a drug, or when do you go for surgical intervention?
Sir, as such, like as you filamentous fungi. Among the filamentous fungi, we have the most commonly infecting fungi are the Aspergillus and Fusarium. So a study conducted by Prajna et al. Has shown that there was no superiority between natamycin or a Orichonozole eye drops among these. Especially natamycin is more potent when compared to Orichonozole among these species. But when compared to natamycin and Orichonozole, the action of natamycin was much more effective in both the species when compared to Orichonozole, especially in case of Fusarium. So as a first line of drug, I would still prefer natamycin.
Yes, everyone would do that.
Yes.
What is the early sign of resolution of the ulcer?
So early sign, like as I said, like we have to interact with the patient as a first review itself, like improvement in the vision and symptomatic relief. The reduction in the pain is the first symptoms wise the patient would say. And as a sign, when we see like there is a blunting of the feathery edges, or we can see early scarring at the edge, one of the edges, a reduction in the infiltrate size, and then reduction in the anterior chamber reaction, hypopion. All these things matters a lot. And even the ulcer size can come down with the improvement in the treatment. So when there is
so what do you mean is when there is an improvement in fungal keratitis severity score in terms of size of the epithelial defect and the infiltration resolving, then you assume that the fungus is getting better.
Fungus is getting better as well. You have to see an early sign of a scarring. So that is how then you can space the interval of follow-up. And
when do you add a drug? You're using primarily natamycin. When do you add some other drug?
As I said, like there is no improvement in the second visit or third visit. Like I usually see the patient on the third day, and then again follow up based on the response. I see them after 4-5 days. In those visits, if I see like there is no improvement, then definitely I will add another drug. Especially we have only limited antifungal drug, either topical natamycin or a Orichonozole. So in that next visit, if I see there is no improvement, I definitely add another antifungal drug. When there is an increase in the ulcer size, increase in the anterior chamber reaction, there is no early scarring, all these things go, and there is an early stromal melt or thinning. So these are the cases which you decide like, okay, you have to add another antifungal agent.
All right. So then when do you stop a drug? You see the ulcer healing. So generally for bacterial keratitis, we tell when there is complete epithelialization, then it means when the epithelium is well formed, that means the ulcer is healed, and you can think about discontinuing medication. But for fungus, do you still continue medicine?
Yeah, I do still continue. I slowly taper the patient with antifungal medications. I observe the patient. Still, maybe even after the complete epithelialization or scarring, I would prefer to have the antifungal medication, especially topical, not the systemic, for at least 2 to 3 weeks. Once I see that scarring and complete epithelialization is, but the frequency of the medication I'll be coming down.
Okay, reduce the frequency, but even after epithelialization in a fungal keratitis, you keep continuing drugs at least for a period of 2 weeks, if I assume.
Yes.
Sir, Dr. Rishi sir is joined. Sir, your comment on discontinuing antifungal therapy.
Oh my goodness! I was actually joining for the next session.
No problem. We'd love to hear
I'm sorry, I missed the talk. So I'm sorry, I'm not sure what the context is.
No, I just asked when do you discontinue a medication after complete epithelialization in fungal keratitis? Sorry, he's lost to the connection. Meantime, Dr. Preeti, I just wanted to know what is the right indication in your practice for intrastromal injections? Indication for the prompt indication for therapeutic grafting.
So with regards to intrastromal injections, sir, I have felt one is a single dose of intrastromal is not adequate enough for all our cases. So we do need to follow them up on a regular basis, maybe once every 2 days or once a week. We need to repeat based on the improvement we are seeing. So a couple of patients who we have tried intrastromal, most of them are from a very poor background. One is the cost of the drug, and second is multiple injections, and patients get very anxious when we tell them that, it's a slow process, you have to wait. So only if it's a well-motivated patient who is willing to come for follow-ups and has a reasonably central small infiltrate, not full thickness, and where, with the medical management, it is not progressing too aggressively, then we would venture out and do an intrastromal, but not to people who are non-compliant, because one dose of intrastromal is not going to benefit me in any way. Or the patient. So we have lost a couple of patients to follow up after a couple of intrastromals. So highly motivated patients only I take up for intrastromal.
Okay. And in addition, regarding lamellar keratoplasty, therapeutic lamellar keratoplasty, as you really mentioned in your talk also, it should be, the ulcer should not be so deep.
Yes.
One is, as much as possible, the infection tend to again re-enter into the interface. The second thing is scarring would be a lot following a therapeutic DALC rather than optical DALC. So that is very case specific. The indication should be, understand. For an ulcer more than 5 millimeter in size with a perforation or an impending perforation,
okay, sir.
Would you directly go ahead with the therapeutic grafting, or will you still plan for a glue and try and wait?
So like I told you, if I have an access to a good tissue, immediately, I think I would directly go in for a therapeutic graft. And if I have a good tissue, it can work out. If it's a small ulcer, I can get away with doing a single surgery. If the graft survives, it can be like a single optical PK itself. I've done that in a lot of cases where it's a localized ulcer, non-healing, and I get access to a good tissue. Luckily, then I do it as a single surgery, goes off as an optical. Glue, like I said, I reserve it only for cases where patients' sugars are high. I'm not able to post them for surgery. Just to salvage the glue, I just put in, because I feel a glue kind of invites more vascularization, and later on, if I'm going to plan an optical PK, that also will be a hindrance to me. So that wouldn't be my first option if I have an access to a tissue.
Okay. I also agree with you that ulcer more than 5 millimeter, if we have a good tissue and if it is not medically getting controlled, I would also think about clearing the infection. So that gold standard PK still is the salvage of the eye and the vision in that case. And regarding CXL, since we have shortage of time, CXL is just something which which may or may not help in drug-resistant cases, and it can prevent our grafting. So that is the only thing CXL can help. And in fungal cases, CXL doesn't work as good as it helps with the bacterial. There are a role for newer antifungal agents. There are role for extended drug delivery systems in treating mycotic keratitis. So with all whatever overview we had given, still fungal ulcer is one of the key challenges in countries like India. And as had been said, nearly 1 lakh eyes are being removed every year annually following fungal keratitis. So early attention, prompt management of fungal keratitis definitely will reduce ocular morbidity and can improve quality of vision and life. So I thank all the panelists. I thank AOS for the opportunity, and I thank all the listeners. Thank you one and all. Looking forward to having a better session in the next AOS, probably physically. Thank you one and all. Thank you.
Thank you to all the speakers. Thank you, Dr. Lionel Raj, for being such a wonderful moderator. Thank you, everyone.